Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and today we will be continuing our discussion of esophageal cancer with a review of some of the important clinical trials that guide our management in this disease site. If you watched the overview lecture for esophageal cancer, we talked about two main paradigms for the management of this disease site. So we know that surgery is kind of the mainstay of treatment, and one paradigm for management is neoadjuvant chemoradiotherapy, followed by surgery, followed by adjuvant nivolumab in a subgroup of patients that don't have a complete response to that neoadjuvant chemoradiation. So if there's residual disease at the time of surgery, some patients can qualify for nivolumab. So that's one paradigm of neoadjuvant chemoradiation followed by surgery, followed by nivolumab for partial responders. The other paradigm is surgery with perioperative chemotherapy. So they kind of sandwich the chemotherapy before and after surgery and omit radiation altogether. What I would like to do in this talk is to first kind of establish the critical trials that back up these treatment paradigms. So we'll start by talking about the critical trials you need to know defining preoperative chemoradiation and the adjuvant nivolumab. And then we will move on and talk about the trials looking at perioperative chemotherapy. There are a couple of trials that have actually compared these two paradigms head to head, so we'll then move on and talk about those trials, and we'll wrap up the video by talking about some trials looking at the management of patients that are not candidates for surgery, and in that case, they just are treated with definitive chemoradiation. So we'll talk about some trials in that setting as well. So those are really my objectives is, as usual, everything we talked about in the overview was kind of a bird's eye view of how we treat things. And in the evidence lecture, my goal is to really get into some of the nitty-gritty details behind the trials that define these paradigms. Let's start by looking at some trials for preoperative chemoradiation. That's the first paradigm we talked about. The seminal trial to know in this setting that kind of defines our paradigm for preoperative chemoradiation followed by surgery is the CROSS trial, and I definitely think this is the most important trial. Prior to CROSS, there were several older studies that were published that compared surgery alone versus preoperative chemoradiation. There's CALGB studies, one from Michigan, there's Irish studies. Some of them showed improved overall survival with preoperative chemoradiation, but then these trials were also criticized for having a smaller sample size, poor design, and poor outcomes in the surgery group as well. There's also a meta-analysis of 24 studies published by Slowquist et al. In the Lancet in 2011. And the meta-analysis showed about a 9% overall survival benefit to preoperative chemoradiation. So I have seen that trial asked about in practice questions. But I think the CROSS trial is kind of understood as the most important trial to know in this setting. So we'll spend a lot of time going through this particular trial. So CROSS ran from 2004 to 2008, and they had around 360 patients with T2 to T4 or node-positive resectable cancer of the esophagus or gastroesophageal junction. And they included both squamous cell and adenocarcinoma histologies, no tumors larger than 8 centimeters by 5 centimeters. And they were randomized to either surgery alone or chemoradiation followed by surgery. The neoadjuvant chemoradiation arm received 41.4 gray and 23 fractions along with concurrent weekly carbotaxol. So they got carboplatin, area under the curve 2, and paclitaxel 50 milligrams per meter squared weekly. And then the surgery was performed around 4 to 6 weeks out from completing chemoradiation. So the dose in the neoadjuvant chemoradiotherapy arm was 41.4 gray and 23 fractions, and the concurrent chemo was carbotaxol, so carboplatin and paclitaxel. The results showed a significantly improved overall survival in the group that received preoperative chemoradiation. So the 5-year overall survival improved by more than 10%. It improved by actually 13%, 47% with preoperative chemoradiation versus only 34% with surgery alone, and that was statistically significant. The 10-year overall survival also had a 13% improvement, 38% versus 25%. So compare that 13% overall survival improvement in the cross trial versus the 9% overall survival benefit we talked about in that older meta-analysis. So big overall survival benefit with the pre-op chemoradiation. The median overall survival almost doubled, so it went from around 25 months with surgery alone up to almost 50 months with the preoperative chemoradiation. The rate of R0 resection was also significantly higher, so only 70% of patients in the surgery group received R0 resections compared to 92% in the preoperative chemoradiation arm. And then the percent of patients that were node positive at the time of surgery was decreased in the pre-op chemoradiation arm, probably because they had some downstaging from the chemoradiation treatment. So the node positivity rate was 30% with pre-op chemoradiation compared to 75% with surgery alone. So huge benefits, right? We see that there's a 13% improvement in the 5 and 10-year overall survival with pre-op chemoradiation. The median survival almost doubled with pre-op chemoradiation, and we see 20% higher rate of R0 resection. And then the other very important number to memorize is that there was a 29% pathologic complete response rate in the preoperative chemoradiation group. This is very important to know, 29%. So you can remember approximately 30%. Now, when they looked at it by histology, there was a higher PCR rate with squamous cell histology compared to adenocarcinoma. So squamous cell histology had a PCR rate of 49%. Adenocarcinoma had a PCR rate of 23%. And if you need a way to remember this, I just think of squamous cell carcinomas, whether it's in the head and neck, whether it's in the esophagus. These are just highly, highly rapidly proliferating cells, and these tumor cells proliferate extremely rapidly, and they also respond very well to radiation. They just have high alpha-beta ratio. So that's how I remember that squamous cell carcinoma had a better PCR rate at the time of surgery. And the numbers are 49% for squamous cell versus 23% for adenocarcinoma. So remember, about 50% versus about 25%. And overall, the PCR rate was in the cross trial was only 29%, so just under 30%. And the reason for that is that they had more patients with adenocarcinoma compared to squamous cell carcinoma. So 75% of the population had adenocarcinoma. So that is very important to realize. 29% PCR rate overall, 49% of those were from squamous cell and 23% of those were from adenocarcinoma. They found no significant difference in the postoperative complications, so just around 6 to 7% grade 5 toxicity in the first 30 days postoperatively for both arms, and they had about a 7% grade 3 or worse hematologic toxicity in the chemoradiation arm. Here are just the Kaplan-Meier curves for overall survival, and you can see the 13% improvement in overall survival at 10 years with the neoadjuvant chemoradiotherapy arm. So big takeaway from the cross trial, there was a significant survival benefit to preoperative chemoradiation, 41.4 gray and 23 fractions with concurrent carbotaxol, and there was a 13% 10-year overall survival improvement. The rates of R0 resection were significantly higher after chemoradiation, 92% versus 70%. And there were significantly higher PCR rates for squamous cell carcinoma compared to adenocarcinoma. But there was a 29% overall PCR rate in this trial. The PCR rate for squamous cell carcinoma was 49% compared to 23% for the adenocarcinoma patients. So squamous cells in general just have higher PCR rate. There was a follow-up publication for CROSS that looked at patterns of recurrence, and you can see that the rate of any recurrence was lower with preoperative chemoradiation, 35% versus 57% in surgery alone. And the rate of distant failure was similar, so around 21% versus 24%, but the rate of combined distant and local regional failure was about half as much with preoperative chemoradiation, and the rate of local regional failure only was cut down by a third, so 3% versus 9%. So the big takeaway from patterns of recurrence of the cross trial is that in the chemoradiation arm, the majority of failures that happened were distant failures. So that's important when we're counseling our patients, right? When we treat them with pre-op chemoradiation followed by surgery, we expect that the majority of failures will be distant failures. Only 5% of patients in chemoradiation arm had in-field recurrences, and only 2% had edge-of-field recurrences. So overall, there were less rates of anastomotic and mediastinal relapse with chemoradiation. There was also less rate of peritoneal relapse. So big takeaway here from the Patterns of Recurrence publication is that the majority of failures for patients that are treated with preoperative chemoradiation followed by surgery, the majority of failures are going to be distant failures. So the CROSS trial is the seminal trial to know for the paradigm of preoperative chemoradiation followed by surgery. We also said that some patients, if they have residual disease, will be treated with adjuvant nivolumab. So where does that come from? That comes from the Checkmate 577 trial. This trial ran from 2016 to 2019, included about 800 patients with stage 2 to 3 esophageal or gastroesophageal junction cancers. All of the patients got neoadjuvant chemoradiation. Most of them had doses ranging from 41.4 to 50.4 gray. They then went on to get an R0 resection, so that means they had to have a margin negative resection, and they also had to have residual pathologic disease. So these were not our complete responders, right? These were the patients that still had residual pathologic disease, either YPT or YPN positive. Those patients were then randomized 2-to-1 to either adjuvant nivolumab for up to 1 year or placebo. And the results showed that the primary endpoint of disease-free survival was significantly improved in the group of patients that got adjuvant nivolumab. So the median disease-free survival was 22 months with nivolumab versus 11 months with the placebo. So we see a doubling of the median disease-free survival. And 71% of the patients in the trial had adenocarcinomas, and on post-hoc analysis, they found that the disease-free survival benefit was seen in both squamous cell and adenocarcinoma histology, also regardless of PD-L1 expression. Only around 15 to 17% of patients in this study had PD-L1 positivity. So whether or not PD-L1 is positive, and the reason we think about PD-L1 is because nivolumab affects the PD-1 pathway, right? It's a PD-1 inhibitor. So regardless of PD-L1 in positivity, all of these patients that still had residual disease and an R0 resection had improved disease-free survival with the nivolumab. Now, interestingly, the original endpoint, or the original co-primary endpoint of the study was overall survival, and that was later changed to a secondary endpoint, and the overall survival results have not yet been reported, but that'll be interesting to follow. But based on the disease-free survival benefit to nivolumab, the doubling in disease-free survival from 11 months with placebo up to 22 months with nivolumab, Checkmate 577 has really established a new standard of care. And for patients that have R0 resection and have still residual disease, so YPT or N positive, after neoadjuvant chemoradiation and surgery, these patients should go on to receive adjuvant nivolumab. In terms of side effects, there was about a 13% grade 3 or 4 adverse effect rate with the nivolumab compared to 6% with placebo. And the most common side effects were pneumonitis and rash. So big takeaway here, Checkmate 577 is the key trial that shows a disease-free survival benefit to adjuvant nivolumab for patients that are treated with chemoradiation followed by surgery who still have residual disease at the time of surgery. And the reason we only treat the patients that have an R0 resection is because these are the patients that had the optimal resection. If they have an R1 or R2 resection, then they really need to be treated with salvage approaches because the goal of surgery is to get an R0 resection. I don't have a slide on the trial RTOG 1010, but I'll just take a moment to mention it here since it also looked at immunotherapy. There are some patients with esophageal adenocarcinoma that have HER2 positive disease, and RTOG 1010 was a trial that looked at the addition of trastuzumab to neoadjuvant chemoradiation for HER2 positive esophageal adenocarcinoma. So unlike Checkmate, where the nivolumab was given after surgery, in RTOG 1010, I believe trastuzumab was given concurrently with chemoradiation, and this was actually a negative trial, so there was no improvement in the primary endpoint of disease-free survival. So for patients that have, locally advanced esophageal cancer, even if they are HER2 positive, adding trastuzumab to their therapy is not standard of care. The only time we add trastuzumab is for adenocarcinomas in the metastatic setting. So we don't routinely add trastuzumab for just locally advanced esophageal cancer, only if it's metastatic. There's one more trial that I'd like to mention in our discussion of trials related to preoperative chemoradiation, and that is the POET trial. The POET trial was a small study and it actually closed early due to poor accrual, but this study included only patients with adenocarcinomas of the gastroesophageal junction, so GEJ tumors only, and they were all adenocarcinomas because they were tumors of the GEJ. So they had around 119 patients with T3 to T4 adenocarcinomas of the GEJ, and they were randomized to either preoperative chemotherapy followed by surgery, or preoperative chemotherapy followed by chemoradiation followed by surgery. So the pre-op chemo arm got 5-FU and cisplatin for 12 cycles, and the pre-op chemoradiation arm got the same exact chemo for 12 cycles, followed by 30 gray and 15 fractions with concurrent cisplatin etoposide using 3D planning. So the dose was much lower. It was only 30 gray and 15 fractions with concurrent cisplatin and etoposide. The primary endpoint was overall survival, and the study was powered to show an improved survival with the chemoradiation. And although overall survival was numerically higher by quite a lot, it did not meet that primary endpoint, probably because it was underpowered because it closed early due to poor accrual. But what they did find is that the 5-year local recurrence and pathologic complete response rates were significantly higher with chemoradiation. So the overall survival at 5 years was 40% with chemoradiation versus 24% with chemotherapy. So 16% improvement, but the p-value did not meet significance. The 5-year local control rate was 38% with chemoradiation versus 21% with the pre-op chemotherapy, and that was significantly different. Also, the PCR rate was 16% versus 2%. So the bottom line from the POET trial, which specifically looked at GEJ adenocarcinomas, there was improved 5-year local control and PCR rate with preoperative chemoradiation for these GE junction adenocarcinomas, and overall survival was numerically but not significantly improved. And again, we have to remember that is in the context of low accrual, so it was probably underpowered. Some major takeaways then to wrap up this first section on the paradigm of preoperative chemoradiation. So the preoperative chemoradiation paradigm has been studied in both adenocarcinoma and squamous cell histologies, and the two most important trials we talked about in this section were the CROSS trial and then the Checkmate 577 trial. So based on the CROSS trial, we know that preoperative chemoradiation followed by surgery improves overall survival. And then based on the Checkmate trial, we know that for patients that have residual disease at the time of surgery, so those patients that are not complete responders, they have an improved DFS when we give adjuvant nivolumab for up to 1 year. So in terms of chemoradiation, the radiation dose used in the CROSS trial was 41.4 and 23 fractions. There are some older RTOG trials that we'll talk about a bit later that went up to 50.4 gray and 28 fractions. And so many physicians continue to treat as per those RTOG trials, and they use doses of 50.4 gray and 28 fractions. 50.4 and 28 fractions with concurrent chemotherapy is also considered a definitive dose for esophageal cancer. And so because we live in the real world where sometimes patients that are treated with pre-op intent may not always be taken for surgery, as radiation oncologists, it sometimes behooves us to treat them to a definitive dose. That way we have done all that we can, even if they don't go for surgery. So as a result, many people will often treat 41.4 gray to a larger margin and elective nodes, and then give a sequential boost up to 50.4 gray for the involved disease. And so that's kind of what I have seen the most often with esophageal cancer in terms of radiation dose. In terms of concurrent chemotherapy, weekly carbotaxol, so carboplatin paclitaxel, is probably the most common regimen, but there are alternate options as well. So you can use basically Folfox or Capox, or you can use capecitabine or 5-FU with cisplatin as well. And then, as we said, for patients that have residual disease at the time of surgery who have a complete R0 resection, we think about adjuvant nivolumab for 1 year based on Checkmate 577. The adjuvant nivolumab is given every 2 weeks for the first 4 months, and then after that it's given every 4 weeks to build up to that full year of dose. And so those are kind of the major takeaways, and hopefully this nicely lays out that first possible treatment paradigm for both squamous cell cancers as well as adenocarcinomas of the esophagus. The other paradigm that exists is this paradigm of perioperative chemotherapy. So it's sandwich approach where we give chemotherapy followed by surgery followed by more chemotherapy. Now, we'll talk about the important trials related to perioperative chemotherapy, but one thing that we will see, and very important to keep in mind, is that this paradigm has only been studied in patients with adenocarcinoma histology. The reason for that is because the perioperative chemotherapy approach really comes from gastric cancer, and gastric cancers are adenocarcinomas. They're not squamous cell carcinomas. The esophagus is unique because superiorly we have that squamous epithelium. So that's an important distinction to keep in mind, is that perioperative chemotherapy, this paradigm really comes from gastroesophageal junction adenocarcinomas, and so the histology is very important to keep in mind when we're thinking about possible options for our patients. The first trial that we'll talk about is the MAGIC trial, which is fairly old. It was published in the early 2000s, but this is a trial of about 500 patients with resectable, locally advanced, stage 2 or higher adenocarcinomas of the stomach or the lower 1/3 of the esophagus. So keep in mind now we're looking at gastric and GEJ adenocarcinomas together. And these patients were randomized to either surgery alone or surgery with perioperative chemotherapy. So the perioperative regimen that was given is something called ECF, epirubicin, cisplatin, and 5-FU. And they got 3-week cycles for 3 cycles preoperatively, followed by 3 cycles post-op. So it was every 3 weeks ECF, and then 3 cycles pre-op, followed by surgery, followed by 3 cycles post-op. Just under half of the patients that were assigned the periop chemotherapy group were able to complete all 6 cycles of chemotherapy. So 42% of patients got all 6 planned cycles of chemotherapy. They found that the rates of R0 resection were not significantly different between the arms. It was 69% versus 66%. They did see a little bit of downstaging from the preoperative chemotherapy, but no PCR benefit. What they did find, however, is that there was a significant overall survival and progression-free survival improvement with the perioperative chemotherapy. So the 5-year overall survival was 36% with perioperative chemotherapy versus 23% with surgery alone. So similarly, they had a 13% improvement in the 5-year overall survival. So the bottom line from the MAGIC trial is that we see a significant overall survival and progression-free survival benefit to perioperative chemotherapy compared to surgery alone for patients with adenocarcinoma of the lower third of the esophagus or of the stomach. And so the MAGIC trial is kind of one of the first trials that established this paradigm of perioperative chemotherapy. The FLOT4 study then kind of improved upon the chemotherapy regimen that was used in the MAGIC trial. So the FLOT4 study looked at around 700 patients, same type of cancers, adenocarcinomas of the stomach or GEJ. They had to be either clinically T2 or higher or node positive. And they were randomized 1-to-1 to get ECF for 3 cycles pre-op and 3 cycles post-op, given every 3 weeks, just like in the MAGIC trial, versus a different regimen of FLOT chemotherapy, given every 2 weeks for 4 cycles pre-op and 4 cycles post-op. The FLOT chemotherapy regimen is 5-FU, leucovorin, oxaliplatin, and docetaxel. The FLOT4 study found that there was a significant improvement in the overall survival and the disease-free survival with this newer regimen of FLOT chemotherapy. So the median overall survival improved by around 15 months. The disease-free survival improved by around 12 months with FLOT versus that outdated regimen of ECF. They had similar rates of hospitalization, so around 25% in both arms, but the types of toxicities they experienced were a little bit different. So with ECF, it's more nausea, vomiting, thromboembolic events, and anemia. With FLOT, it's more infections and neutropenia, diarrhea, and also neuropathy because of that oxaliplatin. So bottom line from FLOT4 is that FLOT regimen showed improved overall survival and progression-free survival, and therefore it has kind of replaced ECF as the perioperative chemotherapy regimen. So the MAGIC trial established this paradigm of perioperative chemotherapy in addition to surgery for adenocarcinomas of the GEJ and the stomach, and it showed improved overall survival with the perioperative chemotherapy. The FLOT4 trial compared the ECF regimen used in MAGIC versus a newer regimen of FLOT and showed improved overall survival and disease-free survival with the FLOT chemotherapy. And then there's one more trial I want to talk about, which is the Top Gear study that asked, does it help if we add some chemoradiation to this paradigm of perioperative chemotherapy? So this trial included the same type of patients that we're seeing in MAGIC and FLOT, so resectable adenocarcinomas of the stomach or GEJ, and they randomized them to get either perioperative chemotherapy alone using either ECF or FLOT, or they were able to get perioperative chemotherapy with preoperative chemoradiation in there as well. So the radiation dose was 45 gray and 25 fractions. What they found is that the patients that got preoperative chemoradiation did have higher rates of PCR, and they had higher rates of response in general. So they had more downstaging, which makes sense because radiation is a local therapy, so locally the tumor shrank more. However, this did not result in an increased rate of R0 resection. It also did not improve the overall survival or the progression-free survival between the arms. The median overall survival was just around 46 to 49 months in both arms. The 3-year rates of progression-free survival were just around 48% in both arms, so not significantly different. They also saw very similar treatment-related toxicities between groups. So Top Gear showed that there's no benefit to adding preoperative chemoradiation in these patients that are getting perioperative chemotherapy. So it's really based on that FLOT4 study that perioperative FLOT therapy is kind of the standard paradigm for some of these adenocarcinomas of the stomach and GEJ. So just to reiterate now, we've talked about 2 kind of standard paradigms for the management of esophageal cancer that have emerged in parallel. So we first talked about the paradigm of preoperative chemoradiotherapy followed by surgery, followed by adjuvant nivolumab for partial responders, and that paradigm applies to both squamous cell cancers as well as adenocarcinomas of the esophagus. This other paradigm that has emerged in parallel is perioperative chemotherapy, and this paradigm comes from studies looking at adenocarcinomas of the stomach and the GEJ together. So when we talk about perioperative chemotherapy, this has really only been studied in adenocarcinomas of the gastroesophageal junction. Of the 3 trials that we talked about, MAGIC, FLOT4, and Top Gear, FLOT4 was kind of the winner in that this is the standard paradigm. So the FLOT regimen is 4 cycles given every 2 weeks, followed by surgery, followed by 4 more cycles of FLOT given every 2 weeks. And the agents in FLOT are 5-FU, leucovorin, oxaliplatin, and docetaxel. As we said, the ECF regimen was used in the MAGIC trial and showed a benefit compared to surgery alone. But then when they compared perioperative ECF compared to perioperative FLOT in the FLOT4 study, there was improved overall survival and progression-free survival with the FLOT4 regimen. And if you're wondering, does it help to add chemoradiation in the setting of perioperative chemotherapy? The Top Gear study looked at that and found no benefit to the addition of preoperative chemoradiation to perioperative chemotherapy. There are some ongoing studies which will be interesting to follow. There's one called the Matterhorn, one called Dante, and they're basically exploring this paradigm of perioperative chemotherapy and seeing if the benefit of immune checkpoint inhibition, so things like pembrolizumab, durvalumab, atezolizumab, does it help to add immune checkpoint inhibitor therapy to our perioperative chemotherapy? So those will definitely be interesting to follow. So now that we've established our 2 separate paradigms for treating esophageal adenocarcinoma, remember the preoperative chemoradiation has been studied in both squamous cell and adenocarcinoma histology. Perioperative chemotherapy has really only been studied in adenocarcinoma histology. How do these 2 paradigms compare against each other? There's a couple of trials that we'll look at which actually compared these regimens head to head. The first of these studies is the NeoAEGIS study. This ran in the 2010s and it enrolled around 360 patients with clinical T2 to T3, N0 to 3, M0 adenocarcinoma of the esophagus and GEJ. And again, remember, because perioperative chemotherapy has only been studied in adenocarcinoma, the trials that are comparing periop chemo to pre-op chemo RT are only looking at patients with adenocarcinoma. The 2 arms on the study were basically the cross regimen versus the MAGIC regimen. So cross regimen was pre-op chemoradiation, 41.4 gray and 23 fractions with carbotaxol followed by surgery. Checkmate hadn't come out yet, so there was no adjuvant nivolumab. And then the MAGIC regimen was perioperative ECF, and then later the trial allowed perioperative FLOT as well, with surgery in between. The trial was designed to show the superiority of perioperative chemotherapy, and it closed early in 2020 after a futility analysis. So they found no significant difference in overall survival or disease-free survival between arms. The 3-year overall survival was 55% with periop chemo versus 57% with pre-op chemo RT. The median overall survival was just around 48 months in both arms. The median disease-free survival was 32 months with periop chemotherapy versus 24 months with pre-op chemoradiation. That was not significant. They found no significant difference in the patterns of recurrence. So oncologic outcomes were not significantly different between the 2 arms. The PCR rates, the downstaging rates, and the R0 resection rates all favored pre-op chemoradiation. And that makes sense because chemoradiation, the radiation is a local treatment, and so locally the tumor is going to respond. It's hopefully going to shrink. So the PCR rate was 12% with pre-op chemoradiation versus 4% with periop chemotherapy. The R0 resection rate was 96% with pre-op chemoradiation versus 82% with periop chemotherapy. Those endpoints were significant, but again, the oncologic outcomes were not statistically different. In terms of the patient-reported outcomes, when they did their quality of life questionnaires, they found significantly worse emotional functioning, pain, and cough at 1 year with preoperative chemoradiotherapy, and then diarrhea was worse with the perioperative chemotherapy. So NeoAEGIS showed no significant difference in overall survival and disease-free survival between these 2 standard regimens, so periop chemo versus pre-op chemoradiation. Naturally, the pre-op chemoradiation saw improved rates of PCR and R0 resection rates because it's a local therapy, but again, no difference in these oncologic endpoints, and NeoAEGIS actually closed early because of a futility analysis because it was powered to show improved outcomes with the perioperative chemotherapy, and they simply did not see that. More recently, a trial called the ESOPEC trial has been presented in abstract form at both ASCO and ASTRO in 2024. And this was another trial that compared the cross regimen versus the perioperative FLOT regimen. So this trial ran 2016 to 2020, and it took around 400 patients with clinical T2 to T4 or node positive, so locally advanced esophageal adenocarcinoma, and they randomized these patients to the cross regimen of preoperative carbotaxol with 41.4 gray radiation followed by surgery, or the perioperative FLOT regimen of FLOT given every 2 weeks for 4 cycles followed by surgery, followed by FLOT given every 2 weeks for 4 cycles. The primary endpoint was overall survival, and they actually showed significantly improved 3-year overall survival with the perioperative FLOT. So the 3-year overall survival was 57% in the FLOT arm compared to 51% in the pre-op chemo-RT arm. The median overall survival was 66 months versus 37 months, and so statistically significantly improved overall survival with perioperative FLOT. Interestingly, they also found improved pathologic complete response and recurrence-free survival with the perioperative FLOT as well. Now, this is a finding that many question because radiation therapy is a local therapy, so you would think that improves the PCR rate. However, in the ESOPEC trial, they actually saw better PCR rate with the FLOT arm. Additionally, the 13% PCR rate with preoperative chemo-RT is much worse than what we saw for adenocarcinomas in the cross regimen. Remember, the PCR rate was around 23% for adenocarcinomas in the cross trial. And that has definitely raised some eyebrows because the PCR rate was 18% with perioperative FLOT versus only 13% with the preoperative chemoradiotherapy. The near complete response was higher with pre-op chemoradiation, 39% versus 25%. But then again, the 3-year recurrence-free survival was higher with the FLOT arm. So 53% peri-op FLOT versus 37% pre-op chemo-RT. So ESOPEC is very interesting. The manuscript, of course, is pending, and we are eagerly awaiting this. But it was presented at ASCO and ASTRO 2024 as abstracts, and it showed a significantly improved overall survival, recurrence-free survival, and PCR rate with perioperative FLOT compared to preoperative chemoradiation. Now, there are some caveats which are important to keep in mind about the perioperative FLOT, and especially in the ESOPEC trial. Now, we know based on Checkmate 577 that we now standardly add adjuvant nivolumab to partial responders. And in the ESOPEC trial, the chemo-RT arm did not use this Checkmate 577 regimen of adjuvant nivolumab, which is the new standard of care. So we definitely need to keep that in mind when we're interpreting the results. And another thing to kind of keep in mind from a practical standpoint is that the FLOT regimen is more toxic, and a lot of times, especially older patients and poorer performance status, have a hard time tolerating this regimen. So when we're actually offering treatments to patients, a lot of times our medical oncology colleagues may be hesitant to put their patients through FLOT, depending again on their age and performance status and so on. So then just to summarize our key takeaways here, remember that for adenocarcinomas of the esophagus and GEJ, perioperative FLOT is an alternative to preoperative chemoradiation, followed by adjuvant nivolumab for partial responders. So the NeoAEGIS trial was negative for difference between these two paradigms, but the recently presented ESOPEC trial showed significant improvement in overall survival, recurrence-free survival, and PCR rates with the perioperative FLOT regimen. We are, of course, waiting the manuscript for further commentary on some of these differences, but in practice, as we think about what options to offer our patients, I think that both of these options are viable options, and it's nice to have a non-radiotherapy option for patients, but there are some practical considerations to keep in mind as well. So number one, perioperative FLOT is definitely a more toxic regimen that can be difficult for many patients. So if we're dealing with older patients, patients with poor performance status, we might not jump for perioperative float. For patients that present with esophageal adenocarcinoma, they often present with severely obstructive symptoms and they're not able to swallow. And so preoperative chemoradiotherapy is more likely to provide relief for those specific symptoms. And so depending on how our patients look in the beginning, that might influence the treatment arm that we pursue as well. And then finally, as we'll talk about here shortly, there are some ongoing studies that are evaluating organ preservation approach for esophageal cancer, and many patients are interested in a non-operative approach. And while we don't have kind of robust data for this just yet, I think we're definitely moving in that direction. And so for those patients who maybe don't want to have surgery at all or maybe aren't even good candidates for surgery, I definitely think that definitive chemoradiation is something to consider. And that serves as a nice segue, I think, to talk about some studies looking at definitive chemoradiation. Remember, for patients that are not operable, definitive chemoradiation is really their only chance at local therapy and curative treatment. So we'll talk about some of the trials that further establish this paradigm. And we'll also mention some ongoing and recently published abstracts that are looking at future directions towards organ preservation with a kind of induction chemotherapy and then definitive chemoradiotherapy approach as well. So I do think that definitive chemoradiation is important to realize is an option for our inoperable patients, and also hopefully in the future can emerge as kind of an organ preservation approach, especially if combined with an induction chemotherapy paradigm. Let's start by looking at some more historical trials that establish some of the common doses that are used in esophageal cancer. So the oldest trial we'll talk about is RTOG 8501, which ran in the late 80s and randomized patients with locally advanced esophageal adenocarcinoma or squamous cell carcinoma to either radiation alone or chemoradiation. The radiation alone arm got a dose of 64 gray in 32 fractions, 50 gray to an extended field, and then a 14 gray boost to the tumor with a 5 centimeter margin. The chemoradiation arm got only 50 gray, so they got 30 gray to an extended field, and then a 20 gray boost to the tumor plus a 5 centimeter margin. And they were treated with concurrent cisplatin and 5-FU given every 4 weeks. The primary endpoint was overall survival, and it was significantly improved with chemoradiation. So the 5-year overall survival was 26% with chemoradiation versus 0% with radiation alone. And persistent disease was the most common mode of failure. So 37% of patients with radiation alone had persistent disease compared to only 25% of patients that got chemoradiation. So RTOG 8501 was very important because it established that overall survival is improved with chemoradiation compared to radiation alone. So if we're going to be treating patients non-operatively, definitive chemoradiation should be standard of care, and the definitive chemoradiation dose in this study was 50 gray and 25 fractions. For patients that are not candidates for chemotherapy who are getting radiation alone, ideally we would avoid this situation, but then the dose would be 64 and 32. But if we're giving definitive chemoradiation, that is definitely preferred, and the dose in this study was 50 gray. There's a few additional studies that asked, does dose escalation help in the definitive setting? And so one of these is the RTOG 9405 or Intergroup 0123 study that looked at dose escalation, and they took patients with adenocarcinomas and squamous cell carcinomas of the esophagus in the 3D era, and they randomized them to either 50.4 gray with concurrent cisplatin 5-FU versus 64.8 gray with concurrent cisplatin and 5-FU. And so in the dose escalation arm, they got 50.4 gray to a large area, 5 centimeter sup and inf margin, and 2 centimeter radial borders. And then they got an additional 14.4 gray sequential boost, so a cone down of the primary tumor only, excluding the regional lymph nodes. The trial closed early because they saw no benefit in the high dose arm. The 2-year overall survival was 31% versus 40% with the low dose radiation, not significantly different. And it was actually numerically worse with the high dose. And the 2-year local failure rates were not significantly different, just about 54% in both arms. The high dose arm actually had prolongation of treatment time because of toxicity breaks, and they had a lower overall dose of 5-FU prescribed, so they were able to tolerate less chemotherapy. So RTOG 9405 is important to know because it was a dose escalation study in the 3D era for esophageal cancer, and it was a negative trial, so it showed no overall survival or local control benefit to 64.8 gray versus the standard 50.4 gray. So in the 3D era, dose escalation doesn't help. The Art Deco trial then was done in the IMRT era, and sadly it was also a negative trial and showed no benefit to dose escalation, this time in the IMRT era. So this trial took, again, patients with both adenocarcinoma and squamous cell carcinoma histologies, and they randomized them to the standard 50.4 gray with weekly carbotaxol versus a higher dose of 61.6 gray with weekly carbotaxol. And they found no significant difference in any of the oncologic outcomes between the arms. So the 3-year local progression-free survival was around 72% in both arms. The 3-year local regional progression-free survival was not significant, and the 3-year overall survival was just around 40% between arms as well. So these were not statistically significantly different at all. And similar to what we saw in the RTOG 9405 trial, they did see slightly worse compliance as well as higher toxicities in the high dose arm. So bottom line, in the IMRT era, we have the Art Deco study looking at dose escalation, and it was a negative study, so dose escalation doesn't seem to help. 50.4 gray with concurrent chemotherapy is still the standard dose. The RTOG and Art Deco trials aren't the only studies that looked at dose escalation. There's also a trial called the Concord Prodige 26 trial that was negative for dose escalation. There's an old RTOG phase 1 to 2 study that actually looked at a brachytherapy boost for esophageal cancer, and it actually showed a very high rate of fistulas, around 12% esophageal fistula rate. So brachy boost is not used in the management of esophageal cancer either. Bottom line from all of these studies, 50.4 gray with concurrent chemotherapy is the standard dose. So for patients that are not candidates for surgery, either they're medically inoperable or whatever the reason, if they're not able to get surgery, we know that their only shot at cure is really definitive chemoradiotherapy. Coming down the pipeline, as we have talked about a little bit, is perhaps an option for definitive chemoradiation for even our operable patients as a chance at organ preservation. So we'll talk about a few trials that are looking at organ preservation. The first of these is the SANO trial, which is a phase 3 study that was so far presented as an abstract at ESMO 2023. This trial looked at patients that were treated with upfront chemoradiation and then randomized to either active surveillance if they had a complete clinical response at 6 to 12 weeks versus standard surgery. In this study, the overall survival was non-inferior with surveillance. The median disease-free survival was 35 months with surveillance versus 49 months with surgery, not significantly different. The distant metastasis rate at 30 months was 43% with surveillance versus 34% with surgery, not significantly different. In terms of the outcomes in the active surveillance arm, 35% of patients actually had a complete clinical response. 48% of them ended up having local regional growth or regrowth, I should say, where the tumor came back in just under half of the patients. And most of those patients managed to have an R0 resection. There was only a 2% R1 resection rate with delayed resection, and that rate was no different than what they saw in the standard resection arm. They did see that there were significantly improved health-related quality of life outcomes in the active surveillance arm at both 6 and 9 months. So the SANO trial is certainly promising, showing non-inferior overall survival, and disease-free survival and improved short-term health-related quality of life outcomes with the active surveillance approach. So this is something that kind of mirrors the shift in paradigm that we're seeing in rectal cancer as well. Of course, we are awaiting the manuscript for further details about the radiation therapy as well as the surveillance procedures in these patients. So this is one potential trial looking at just upfront chemoradiation followed by active surveillance. There are some additional trials, and again, we're not going to be able to talk about all of the possible studies here, but there are some additional trials investigating the possibility of induction chemotherapy prior to chemoradiation. And if you think about it, we know based on the cross-trial data, the majority of these patients fail distantly. And so induction chemotherapy might actually be really valuable to help provide some distant control as well. And so there's a couple of phase 2 trials we'll talk about here that are looking at induction chemotherapy approaches. There's one phase 2 study out of Japan called the CROC study looking at organ preservation for squamous cell carcinomas of the esophagus. This was published and they treated all of their patients with induction docetaxel, cisplatin, and 5-FU given every 3 weeks, and then assessed response on CT and endoscopy. And if they had a remarkable response defined as a reduction in tumor to T1, less than 1 centimeter lymph nodes on the short axis, and downstaging to a stage 1A tumor after 3 cycles of the chemotherapy, then they went on to get definitive chemoradiation to 50.4 gray with 2 cycles of cisplatin 5-FU. Otherwise, they just went on to get surgery after the induction chemotherapy. They actually had decent response rates, so 58% had a remarkable response to the upfront chemotherapy, and then 90% of these underwent a clinical complete response after undergoing definitive chemoradiation. So the 1-year progression-free survival was 90%, the 3-year overall survival was 74%, and the 3-year esophagectomy-free survival was 45%. So almost half of the patients never had to undergo an esophagectomy, which is great. The toxicities were kind of high, so they had a 100% grade 3 to 4 neutropenia, 83% leukopenia, and other side effects including anorexia, anemia, nausea, and fatigue with that induction chemotherapy regimen. And they did also find that a PET response after 2 cycles of DCF was associated with overall survival. So the CROC phase 2 study definitely shows a feasibility of an organ preservation approach with induction chemotherapy followed by definitive chemoradiation for good responders. It is, however, a fairly toxic regimen and might not be for everyone. Another ongoing phase 2 trial, this time for early stage esophageal adenocarcinoma, is an organ preservation trial called the PRESTO study. So this study is actually enrolling patients with T1 to T2 N0 esophageal adenocarcinoma, so very early stage adenocarcinoma, and they're treating them with upfront FLOT for 2 cycles with durvalumab, so it's kind of chemoimmunotherapy. And then they're going to be getting radiation to 50 gray and 25 fractions with concurrent FOLFOX. And then afterwards, they'll be reassessed and undergo surgery if local persistence or maintenance durvalumab if they have a complete response. So the reassessment is going to involve EGD as well as biopsy, endoscopic ultrasound, and CT or MRI. So the primary endpoint will be the rate of clinical and pathologic complete response at the time of reassessment. So it's nice that they're getting an EGD as well as a biopsy. So this will definitely be an interesting trial to follow for adenocarcinoma as well. And I think it just, again, highlights that ongoing studies are looking at definitive chemoradiation, and a lot of them are adding induction chemotherapy, again, to try and help with that distant recurrence rate. So just to kind of summarize the most important things we've talked about here, there's really 2 acceptable paradigms for esophageal cancer right now. So the first paradigm that applies to both squamous cell and adenocarcinoma histologies is the CROSS and Checkmate paradigm, which is preoperative chemoradiation followed by surgery, followed by adjuvant nivolumab for patients that have a partial response. And then the other paradigm, which really only applies for adenocarcinomas, is the perioperative chemotherapy paradigm. So that is preoperative FLOT, followed by surgery, followed by postoperative FLOT. In the future, we will hopefully start to see more organ preservation approaches as investigated in the SANO phase 3 trial, and as more kind of ongoing phase 2 trials develop with the investigation of induction chemotherapy, hopefully we can kind of move towards organ preservation, just as we have started to do in rectal cancer. For our patients that are not candidates for surgery, we really treat them with definitive chemoradiation. Otherwise, again, we're doing either pre-op or peri-op therapy. But for patients that will never be able to get to surgery, definitive chemoradiotherapy is the standard treatment for these patients. As we saw, we looked at the RTOG 9405 and Art Deco studies. Even in the IMRT era, there's really no benefit to dose escalation. So the standard dose that we treat these patients to is 50.4 gray. And even when we're treating with preoperative intent, although the cross trial looked at 41.4 gray and 23 fractions, I have seen a lot of folks use that RTOG dosing, and sometimes we treat a larger area to 41.4 gray, and then we kind of either sequentially or sometimes simultaneously can further boost just the tumor and the involved lymph nodes. So 50.4 gray and 28 fractions is really the most standard dose, I would say, for esophageal adenocarcinoma. And then again, just to reiterate, we've looked at some ongoing efforts to evaluate organ preservation. So we looked at SANO, which is phase 3. We're awaiting the manuscript. And then we have the CROC and the PRESTO studies that we talked about. Before we close out, I just want to reference a nice set of esophagus contouring guidelines by Wu et al., published in the Red Journal in 2015. The biggest thing I want to reiterate here is the margins that we use when we're contouring the esophagus. So we always contour our primary tumor, and then for the clinical target volume margins, we have to be very generous, especially in the superior and inferior direction. So in these guidelines, they actually recommend 3 to 4 centimeters in the sup-inf directions, and then radially, we can go around 1 centimeter, cropping out of barriers to spread, such as the heart and the vertebral bodies and so on. But esophagus is very, very lymphovascular, and there's high lymphovascular connections, especially running in the sup-inf directions. And so we need to be very generous with our sup-inf margins. The only time we can be a little bit conservative is if we're extending into the stomach. The guidelines say that if we're extending inferiorly and going into the stomach, then we can do kind of a 2 centimeter mucosal margin into the stomach. So remember, 3 to 4 centimeters sup-inf margins, 2 centimeters if we're going into the stomach, and then 1 centimeter radially for our primary tumor. For involved lymph nodes, we typically add a centimeter to them, and we definitely do consider elective regional nodal coverage depending on the location. So if it's a distal GEJ tumor, we might want to include the celiac and the left gastric nodes, and these tumors can spread to regional nodes, so I do think elective nodal coverage is important for esophagus. So celiac and left gastric nodes for distal esophagus and GEJ tumors. And then for tumors that are higher up above the carina, we think about including the bilateral supraclavicular and mediastinal nodes. Again, it's not mandatory, but it's definitely something to highly consider. And then once we create our CTV volumes, it's also very important for esophagus to get a motion study, because of course the esophagus is in the thorax, so it's going to move a lot with our breathing cycle. And we need to create ITVs based on the motion study and make sure that we're including everything that is possibly at risk of spread. And we do want to ask our patients to be NPO 2 to 3 hours prior to simulation and treatment, because the stomach volume is very important, and we don't want to increase the size of the stomach. We want them to be NPO to keep that as small as possible. So these are a really nice set of guidelines. I always reference these when I'm working on esophagus contours, and I just wanted to provide that reference so that you can refer to it if you're working on contours. That brings us to an end of esophageal cancer evidence. As always, we are never able to go over all of the possible studies that exist, but hopefully we've gone through some of the most important studies to know and kind of laid out the studies in a context that makes sense. And, hopefully this helps you to understand the big picture of why we do what we do when it comes to esophageal cancers. Thank you so much for your time and attention.